And I would like next to welcome Dr. Krishnan. Let me get my notes there. We have a double act, brilliant. So Dr. Mani Krishnan is a consultant in old age psychiatry and the chair of the old age psychiatry faculty for the Royal College of Psychiatrists. He's actually from my own mental health trust, TESS Canberra Valleys NHS Trust. He won the Innovation Champion Award, and he was nominated by his colleagues for going above and beyond his day-to-day duties to improve patient care and experience. And he's joined by Lauren Bennett, who is the Innovations Project Manager, also at the same trust. So welcome, and over to you.
Thank you, Lena. So, as Lena said, it's a double act. Lauren will nudge me when I should shut up because I don't know how to shut up. So, thank you for our previous speakers. So, I'll start with a bit of a joke, take it in a positive sense. So, Henrietta said it took 11 years to get her birthday cake, and Sri said 17 years of consultant. So, for us, Guy said about digital, so we got the digital solution. It took 1 year for us to get it to a bit of a pilot. I'm only thanking COVID. If COVID wasn't there, I'll probably coming back 17 years later talking about this digital solution. So I just want to look at how we can use the challenge to our opportunity and how the pandemic broke some of those bureaucratic barriers. Here is the hold the thought, because since the pandemic's over, they've all come back and stopped us. So that's the heads up. Again, already Lena has introduced us. So the problem, again, those who work in psychiatry, we know, I think those in psychosis team, early intervention, crises, we day in and day out, we start patients on antipsychotic medication, stop them, restart them, and various things. And again, the biggest problem is some of those cardiac side effects, arrhythmias, syncope, QT prolongation, if people know, and then tosse de pointes, which causes the sudden death. And so normally the pathways suggest you, if you initiate a patient on an antipsychotic medication, you would normally do a baseline ECG to look at the QT to make sure there is no baseline QT prolongation. And when you titrate the dose, or patient is on high dose antipsychotic. However, during lockdown, like anything else, mental health was forgotten. They didn't think physical health is of importance to our mental health people. So I have nothing against GPs because I'm married to one, I'll be shot otherwise. They stopped community ECG services. The acute hospital said routine ECGs are stopped. Mental health services, we had the lockdown, social distancing. So literally, we were just going with a blind thing of starting patients, hoping the God will save them. So, and again, I'm not sure you were aware of this device. How many of you have seen a tiny portable device to do an ECG? 2. Right. So in case if you are wondering, it's as big as this. Yeah. And it does 6-lead ECG, no wires. That's the point. No wires, no stripping, no sticky plasters. Yeah. So our routine practice would have been this big 1.5 to 3.5 kilogram of an ECG machine. Some of our support workers, those who have ECGs in the mental health services, will carry around, or in an ECG clinic. They do a paper ECG as a consultant. It stays in my docket until I decide to look at it. I'm being blunt here. That's what happens in routine practice. And then decide on, if the QT is produced by the automated reading, and then you make a decision on whether to start, stop, or whatever. So as compared to the device, what I was showing, basically, you hold it in your 2 thumbs and then stick it on your skin of your left knee and connect your Bluetooth device, your iPhone or Android, you get a 6-lead ECG. So that's the difference. So I've been talking to the company pre-COVID, how can I bring this, because I saw it in a conference. They said, no, it's not regulated in the UK yet. And then COVID came along, and the FDA had an emergency authorization to use the device, not for antipsychotic, because the hydroxychloroquine also prolongs QT. So suddenly, when a disease that is pandemic, the rules got broken. They said, you can use it for QT prolongation. So this is where the opportunity came. So April 2020, I contacted the company and say, can we use it in psychiatry? I said, no, we're not sure. So, and then, because that's from America, we need European regulation at that time. So the European guidelines came on management of cardiovascular disease during COVID pandemic. That again confirmed the use of the device for QT monitoring. So what we did, so we had a gold command. I'm sure every trust had a gold command during COVID. And incidentally, I was member of the gold command, so I got a 2-paragraph on an A4 sheet, a proposal to use this as a pilot in our trust to get 30 devices. Gold command said yes to anything that will improve patient care at that moment in time. So I got the go ahead, and is it your time?
Yep. Thanks, Krish. Right, can we change this?
Yeah.
Right, thank you. So I got a phone call from Krish one day. I was sat in my office. I said, I've got this new job, Krish. I'd worked with him previously in the research team. I said, I'm now working in the innovation side of the research team. He said, well, funnily enough, I've actually got an idea of an innovation that can really help our service users. So we discussed the device and how we could implement it within our trust. We got some funding from the Academic Health Science Network North East and North Cumbria, who we work very closely with in innovations. We procured 30 devices. We shared them among community and inpatient teams. This was older adult psychiatry teams and general, and we developed a local operating manual with our clinicians. We wanted to know, what would you like within this manual? What's really important to you? And we really wanted to standardise this manual across the whole trust. So we co-developed the operating manual. As Krish said, we got approval from Gold Command, and we designed some feedback surveys for staff and service users who were using the device to complete. And we asked for a comparison of the 12-lead ECG device, or usual care, compared to the 6-lead device, which Krish has shown. So we did a cost and time analysis that was really successful. We got some feedback from staff, feedback from service users, and as a result, NHSX at the time funded a project to expand our original pilot project and validate it. So we worked with CNTW NHS Trust, a bit further north from us, and we got 140 devices spread between the two trusts. We did the exact same project, and we did educational material we made between the two trusts, so we co-developed that between the trusts and co-developed the operating manual again, just to make sure that everybody was using the same materials and that staff were using the device standardised across both trusts. And this was really successful again, so the project was validated. And as a result, 1,200 devices were procured and distributed across the whole of England, so for all NHS trusts to procure and use within their services. Okay, I'll hand back over to Krish.
So again, just to probably people will be asking, so 140 to 1,200, where are those other 1,200? So I'm not ashamed to say they're probably in some cupboards in some NHS trusts, simply because you need people and passion to drive innovation. Otherwise, again, you get that hindering thought, isn't it? This is not regulated, there is no nice approval. And then in my own trust, I remember somebody complaining to me, saying that somebody is pushing this dodgy device. Dr. Krishnan, can you sort them out? So I said, it's me. So again, that's how, the rumor mongering that happened. So, but again, I was at a conference in India, so they came across this, and then currently they are doing a pilot in one of the medical universities. Again, I'm not ashamed to say that they are probably well ahead of us because they break barriers very quickly. So that is one thing that's happening, but we are collaborating, so we will get some results. So just to go through our journey, so April 2020, we got the FDA clearance, and June, we got the ESC approval, and then about October, we started the initial pilot. August 2021, we got a local expansion, and then September, we got a national expansion. And then, probably you could see the timeline, COVID was dwindling down. So we had NICE. Again, I would say, like how people claim of first, we were the first guinea pig for this new process of NICE. Those who have worked with NICE, it's not a monthly affair. You're talking about a decade sometimes. But this one, the key principle was early value assessment. They wanted to hasten some of those technology innovations so that you're not going through so many other processes. So we met up, we had about 3 meetings, and August 2022, they actually published a draft guidance for people to use. Within a week, they took it off and paused it. Again, without being angry or anything, just to tell, it was stopped because of a technical snag, not because of the efficacy or safety of the device. They all have to have a regulatory process called, those who in project management will know DTAC process. It's a digital technology, a device something. I don't even know the expansion. But because that was not done by NHS England, NICE said we can't give the evidence. So August 2023, we are still waiting. So we were hoping it would be out yesterday, then we could have said, but it is any minute, it might be coming. So we are awaiting guidance. So watch the space. So in our pathway, is that yours? No, this is yours. Yeah. So basically, I've already given you the kind of a gist of it, how we do it. So whenever we want to initiate a medication, I've explained how we do it. There are videos, there is a QR code at the end of the presentation that you can go through, and this is how they do it. You've got the picture there. They hold it in 2 thumbs and onto the skin of the knee, and we have found some practical things. Those who have a very tight tights or jeans, you can just place a drop of water and put it on the cloth. It works. You just need electrical contact. Or you can put it on, lower the socks down, and you can use the left ankle as well. And I had a difficult one. We had a below knee amputee. It still works. Above knee amputee, it still works, as long as you point your electrode on that area of the lower limb. Basically, you're creating an endovan triangle to get the 6 lead. And then it gets sent to us, and the only thing what we will say is the limitation is, unlike the paper ECG, we need to calculate the QT. Again, you don't have to be a professor of mathematics. You just need to calculate number of small squares between the Q and the starting of the Q and end of T. And there are well-validated apps available. You stick the number of squares and heart rate. It'll give you 4 different types of QT corrections. So, it is simple, I would say. I would say, won't I? So, got some validation? Yeah.
Thank you. So we tested the device and the pathway with 272 patients across our trust. We compared the device to the 12 leads or usual care, and 100% of our service users agreed that it was easier to use for them, it was more dignified and private, it was least intrusive, it was most comfortable, and every single one of our service users said that they would prefer this 6-lead ECG compared to the 12-lead in usual care. We did get some qualitative feedback as well, such as it was loads quicker, it was less intrusive, easier and cool, and there's no sticky stuff left on you, so that was nice. We did get staff feedback as well. I think, I won't go through them all, but I think the one that stands out most to us is, if you took it off me, I would cry. So that was some nice feedback. We did a small cost-time analysis just to see if there was any cost or time savings using the device, and this is what we found. So 17.5 minutes saved per ECG, and going back to, this amount of time could be spent doing psychological interventions or treatments for our service users rather than doing an ECG, a 12-lead ECG. Around 72 hours saved per team per year, and then we've got some cost savings, which are obviously quite large on there as well. So that's some of our cost and time analysis that we did.
Thank you.
Next question.
So again, just don't question the data. It's a back of the envelope calculation. So that is something, it's one of the things we're planning to do a formal research on that. But it does, again, our support workers, they spend an hour going and doing an ECG. Now in my team, every member of Band 6 nurses have a device. So when they see the initial assessment, they think the patient might need antipsychotic, they already do the ECG, ping it to me. So we do save time and effort as well. So again, like Laura's story, we need the patient's voice. They are telling, because we've got patients with trauma, patients with multiple other problems. They wouldn't like to be stripped by male or a female. And the recent one of our forensic psychiatrists said, this 40-plus-year-old man in a restricted environment, first ever ECG he had was with this device last month. So you could say he has never had an ECG in his life. He has been on HIDAT forever. So those are the positive qualitative feedback. Again, I've already mentioned about nice early value assessment, but they have just published saying that it should be coming any minute. But the good news is it is DTAC compliant now. So we will be getting a draft guidance from NICE fairly soon, asking for more evidence, but also asking for us we can use it in trust. There will be questions I'll be happy to answer towards the end. Other uses, so even though in mental health we are still grappling, it's being used in oncology, methadone clinics, Top Hat study, one of the Parkinson's studies, tuberculosis, breast cancer. So it is being used. So it's not like something, it's like I keep saying, forgive the product thing. It's not a middle of the little item. It is a fairly well validated item. And it is used in, across the world as well, US, Europe, and in India. So I already mentioned the other uses, Top Hat study, and the breast cancer. There are 14 centers in UK. The future, so the product developers have got what they call an instant QT. So I put the step where we have to manually calculate, but they have got an algorithm that will actually give you the instant QT. So you can see, while I was in India, it is available there. So this is one of the screenshots. It actually gives you the QT. So it also eliminates that extra 5-7 minutes of us working on that. So that is something, again, I don't want to come here 7 years later saying that we are now doing this. I would like this to be now. But Mayo Clinic also in 2021 thought about like how Guy mentioned about 13 hours to autism assessment. All QT prolongation serious. So they've got an AI algorithm looking at the patient demographic, patient risk profile, cardiac profile. We could find out which QT prolongation is ominous, which one is benign. So they are getting some AI algorithm. That is, again, watch the space. And I'm really hopeful we get this device up and running in our mental health trust, because there's already a 12-lead program that's coming. So we do need to look at that. So coming back to our reflections from this project, I still want to thank COVID. I'm not missing COVID, but on this bit, I do miss, because the walls have come back again. And clinical curiosity, knowing hydrochloroquine causes QT, and then using it in psychiatry, and the patient choice is important. Challenge the status quo. Co-creation. So we have a big patient carer participation group in our trust. We brought them from the word go. We had focus group, we had independent people interviewing them. As Lauren mentioned, 100%, if given a choice, they would go for the 6 lead rather than a 12 lead. And using opportunity to drive innovation. So I've already mentioned the barriers, but some of them barriers, unless you have the drive, passion, and a bit of a grit, it will be in the cupboards of our offices. So that's the key kind of a message for me. And thank you from us.
Thank you, Dr. Krishnan. Lauren, thank you so much for bringing to our attention an important issue, looking after the physical health of service users who live with severe mental illness. So thank you very much.